This week on the BackTable Podcast.
The best immunotherapy we have for cancer, across all cancers, right, is still BCG. The response to BCG in bladder cancer is much better than immunotherapy for lung cancer or melanoma, what have you. So yes, BCG is still the reigning king, the number one recommendation, but there's a global shortage. And in the era of global shortages, Mike O'Donnell and his group, and then all of us subsequently, have adopted gemcitabine and docetaxel as a very reasonable alternative. And because of that, we have Max Cates leading the BRIDGE study, which is gemdosi versus BCG. So I will offer that study to my patients because we have it here and say, hey, would you like to enroll in the study? We think they're two equivalent arms. But if the patient says, what's current standard of care? It is BCG, induction, and then the SWOG protocol maintenance.
Hello, everyone, and welcome back to the BackTable Podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. Now, a quick word from our sponsor. From concept to completion, there's a lot to consider when building a Theranostics or PSMA PET-CT imaging program. It's nearly impossible to be an expert in every aspect of this care pathway, but the success of your program depends on it. Get the support you need from an experienced team. Open your web browser and search Siemens Healthineers Theranostics. You'll see the complete Theranostics care pathway and how they can help you customize it to meet the needs of your prostate cancer patients. Visit their website or stop by Siemens Healthineers booth at the local and national American Urological Association and large urology group practice association meetings. You deliver the care, they'll deliver the rest. Now, back to the show. This is Aditya Bagrodia as your host this week, and I'm very excited to introduce our guest today, Ashish Kamat from MD Anderson Cancer Center. Welcome to the show, Ashish. How are you doing today?
Great, Aditya, and it's a pleasure to be here with you.
Well, Ashish, the pleasure's all mine. I mean, I feel like this is a conversation with a true living legend in urology, particularly as it pertains to bladder cancer, clinical management, translational management, really driving the next generation of treatment. A lot of it's really come out of your lab. So today, the focus of our conversation is going to be on high-risk, non-muscle-invasive bladder cancer. And Ashish, maybe I'll ask you to just take a walk down memory lane. 10 years ago, what did this conversation look like when you met somebody with newly diagnosed high-risk non-muscle-invasive bladder cancer?
You know, it's interesting you asked that, right? Because 10 years ago, there wasn't that much activity in the world of bladder cancer. We had BCG, and we had maybe a little chemotherapy here and there we could trickle in. And the conversation with patients really was more about, okay, let's try A. If A doesn't work, let's try B, and then move on, right? And in some ways, it made that conversation with the patient simple, but a little too simple. And I'm glad that things have evolved. The understanding of bladder cancer, the understanding of risk stratification, what exactly is high risk, what's intermediate risk, what's low risk, and how do we actually tailor and personalize treatment to the individual patient is really a fascinating evolution in a very relatively narrow subset of patients that we treat in urologic oncology. So it's been a remarkable improvement in everything that we've seen, and you've been part of it too, over the last 10 years.
Couldn't agree more. I mean, obviously that's a nuanced question in and of itself, but let's jump on into it. You know, so obviously you're at a quaternary referral center. You're probably not seeing tons of microhematuria, gross hematuria, but just so we can kind of level set, new diagnosis, whether that's suspicious imaging, staging for somebody that you're even remotely thinking that they could have a high-grade bladder cancer?
Yeah, you know, like you alluded to, most patients that come to see me already have a good set of workup being done, right? But what does that workup consist of? Clearly nowadays, most people default to CT urogram as a workup for hematuria. So patients have CT urograms. They have usually a UA that shows blood in the urine. And if they don't, I think a cytology is critical before you take the patient to the OR because it helps us kind of know before we go in, does the patient have high grade or low grade, right? And if it's a high grade positive cytology, you tend to think of the TURBT a little bit differently. You know, the TURBT is one of these really underappreciated and under-recognized nuanced procedures that we tend to leave to junior residents. Rightfully so, because they need to learn how to do it. But it's the first and most important step in the management of every bladder cancer patient. So knowing what you're going to do when you go in there, having a game plan. If it's high-grade disease, it's likely to be high-risk disease, resect the tumor, get muscle, send a separate specimen of the base of the tumor, maybe do some directed biopsies or blue light directed biopsies. So it really helps to have that cytology before you go in as well.
Whether it's an initial or a restaging, you're with the fellows and the residents, what is the kind of, this is what an Ashish Kamat TURBT should look like. These are the critical elements of the operative report. Can you walk us through that a bit?
It's a game plan, Aditya. You got to have a game plan, right? Whether it's doing it with me, doing it with someone else, develop a game plan, refine it, and stick to it. And that game plan should pretty much involve some of the elements that we talked about already, knowing what the cytology is, knowing the location of the tumor, because it starts with that communication with the anesthesiologist. This tumor is lateral. I think I'm going to have to go deep. I might get that obturator reflex kicking, me and then causing a perforation. Let me get the patient paralyzed, right? So the positioning, all of that goes into play. The actual TURBT, you need to, and again, we know this, you and I know this, but for the residents and the fellows, they need to know the nuances of the energy device they're using. I tend to prefer bipolar, nothing against monopolar. I tend to prefer bipolar, but even within the bipolar machine, there are nuances of settings that allow you to do a little bit more, a little bit less, do like an on-block versus a non-on-block resection. That game plan needs to be developed before you actually put the scope in. Once the scope's in, have a plan to map the bladder, like locate the different areas of the bladder, know where the tumors are, and then develop a plan for resecting the tumor that's going to give you the most information first, knowing that you're going to do a complete TURBT. But if something happens, right, anesthesia-wise or bleeding-wise or something, know that the best bang for your buck tumor is the one you should get out first.
Yeah, I love that. And I think it really behooves us, always tell the residents, especially when they're in scenarios that are resident dominant, let's just say, the basics, the size, the focality. Did you visibly resect everything? Did there appear to be any carcinoma in situ? Because our pathology colleagues, by all means, they're trying their best, but these can be challenging situations. Are you using blue light generally in the operating room for your resections?
I use blue light quite a fair amount, but selectively, right? Because if you look at the studies that we and others were part of, the original studies in 2008, really the indication was for anybody with suspicion of CIS or papillary disease. Well, the indication was papillary, but we use it for anybody with suspicion of CIS as well. And that's a little bit of an oversimplification. So I tend to use it a good amount, but it's not 100% penetrance in the TURBT because you don't really need it for every patient. But you made a really good point, which I want to bring up. Those points that you mentioned, focality, number of tumors, location of tumors, I think it's crucial, whichever record-keeping system you use, and by you I mean the audience that's listening, whether it's Epic or otherwise, develop a template that mandates that the operative note has all those elements, right? Did I get muscle? If I didn't get muscle knowingly, why not? There might be a reason. And if I didn't go deep on purpose because, for example, I thought it's a low-grade disease, that's fine. Did I use perioperative chemotherapy? Yes, no. If no, why not, right? Was it too close to the UO, etc.? Did I use blue light? Yes, no. If no, why not? So those should be just part of our routine checklist that we have in our operative note templates. So you can't get away by not documenting them, right? If it's in the template, it forces you. It's a hard stop. You have to fill in those boxes.
Perfect. I love that. So you've done the TURBT, and I mean, TURBTs, I tend to agree with you. They're such a critical piece. They're fascinating. The tips and tricks are abound. But let's say, the patient's in your office in a week or so, the pathology's back, they're doing fine. Let's focus our conversation on patients with high-grade disease. The low grades, we'll just kind of, if this is okay, put those in a separate category as a little bit of a different beast here. But walk us through how this conversation starts with you.
So again, I want to compliment you for saying high grade and not high risk, because if you really look at the risk classification, the AUA includes high grade disease as intermediate risk, right? The International Bladder Cancer Group doesn't do that. SITC doesn't do that. And you also said high grade implying high risk. So right off the bat, I think any high grade tumor should be considered high risk. And that's how I have my conversation with the patient, right? Because if the tumor is high grade, and we nowadays talk about low grade and high grade, we've gone away from the nuances of grade 1, 2, and 3, even though there's a push now to go to 1 through 3 and 4. But let's assume your pathology does high grade, low grade, and the patient is high grade disease. What you are worried about on behalf of the patient is not just the potential for recurrence, but for progression of disease. Progression of disease, understaging of disease. So it's a conversation that starts educating the patient that, okay, we're going to work towards recurring the number of times this tumor comes back. But at any given point, we have to worry that this tumor is going to progress. And if it progresses either in grade from low grade, which I know we're not talking about, but goes to high grade, or stage from TA to T1, and definitely T1 to T2, we've got to have a trigger to go to a treatment that's going to avoid the morbidity of metastatic disease and the mortality that accompanies that. So that's sort of where I level set with my patients going in, because otherwise too many patients come to see me, and I'm sure they come to see you from sometimes referring centers, where they're told, oh, it's just a superficial tumor, don't worry about it, like, we got it. I think that term superficial is a misnomer, especially for T1 disease. So it's very important to set expectations in the patient's minds as to what the journey is going to entail.
Perfect. That's about it. We've got two kind of outcomes of interest here, recurrence and progression. Recurrence is oversimplified or inconvenient. Progression events, these are life-altering interventions, a threat to your life, and these are the ones that we really are trying to ward off here. So we've kind of had that conversation, and I will say that, creating some of this patient education on the front end where I tell them, once your pathology is back, I'm going to share that with you so you can educate yourself. I mean, BCAN's a wonderful resource, of course. I've also created a couple of videos that I share with patients. By all means, this podcast is going to go on there so patients can kind of think about how physicians are thinking about it. So when they come in, we can really start having a conversation, not just about grade and stage and muscle and LVI and variance and all of that. But let's you and I have that conversation. So we've kind of set the patient. Now we're going to dig into the pathology report and kind of walk us through what that's like from your lens. And importantly, in today's day and age, with all the tools that we have, where you may be thinking the next intervention for this patient may be cystectomy, for instance.
Yeah, great question. When you're looking at a pathology report and we're looking at it, we're looking for clues from our pathologist. So obviously knowing how our pathologist reports is important. And if they don't report all the points that you and I are going to talk about in the next few minutes, I think the listeners should go to their pathologist and say, hey, I need all this information, right? So the pathology report should clearly state the grade and the stage of the tumor. It should clearly state if there's invasion of X, and that X is either lamina propria or muscle, because oftentimes you'll see a pathology report just say papillary high-grade tumor, but there's no mention of does it invade the lamina propria, yes or no. So it's important to know that it doesn't invade the lamina propria, because that's a different beast, right? Lymphovascular invasion, very important to state if lymphovascular invasion is present. If there's any histologic subtype, what we used to call variant histology, micropapillary disease, small cell carcinoma, neuroendocrine features, etc., they need to be mentioned, and ideally the percentage of that histologic subtype needs to be mentioned. If there's muscularis mucosae present, mention it. If it's involved, mention it. If it's muscularis propria, present or absent. It's really important, right? Because what you and I are trying to do now is figure out, is it safe to give a particular patient the opportunity to save his or her bladder? Is it something you would recommend to your brother or uncle or father, right? Or would you say, no, this tumor is really, even though it's non-invasive, it's aggressive enough that, hey, either we really embark on a experimental journey or a clinical trial to try and save the bladder, or I really should be telling you, you need a cystectomy up front. If someone's got T1B disease, widely invasive, lots of disease in the bladder, LVI, micropapillary, you and I know that if we try to save that patient's bladder, they could metastasize while you're working to save the bladder, right? And even though now we have EV Pembro, which is giving you 30 months, it's still only 30 months. It's less than 3 years once the tumor metastasizes.
Absolutely. And I think it goes back to what the bladder looks like. I mean, I feel like we all have a sense, and sometimes it is challenging to verbalize, but if it is multifaceted focal, multinodular, extensive carcinoma in situ. Certainly is distal bladder with saving. Sometimes when the disease is that bad, it doesn't really make a lot of sense. So I do find, just to be totally honest, that it's harder and harder to have the conversations of you need a cystectomy because we may miss a window of an opportunity for cure in the next 3 months. But there are patients that I'm worried about, and there's always this catch-22. It's the younger patients that you don't want to get it wrong at all because the opportunity cost of that, 3 years of life with EV of Prembo versus 40 years of life with a neobladder or a conduit, that's high stakes. And in the same breath, this is precisely the person that you want to maintain their urinary function, sexual function. We'll kind of jump into this, but how do you think about that?
Yeah, so obviously it's been 20 plus years that I've been doing this. And initially, just like you mentioned, you try to be more forceful with the patient, more aggressive because you're like, okay, let's do the cystectomy, let's get you cured. And patients don't want that, right? So what I've evolved into, educating my patients over the years is I say, hey, your safest course of action is a radical cystectomy. Do you want it? Yes or no? And about 10% of patients that come to see me will, in fact, jump on an initial radical cystectomy if I counsel them on it. So it's probably a higher number than many you would see because 1 out of 10 is still a large number of patients wanting cystectomies. But let's assume most patients don't want a cystectomy. Then what I tell the patient is, okay, anything we're going to try is to try to avoid that cystectomy. But at any point if this tumor does not behave well, if our treatments don't work, then we are back to square one talking about the cystectomy. And that helps me and the patient because at the back of their mind, they know they have to keep the appointments. They have to be particular about their BCG schedule. And I know we'll talk a little bit about that. They have to be particular about their cystoscopies. They can't just say, I'm a busy executive and I can't come in for 6 months for my check, right? But also, if the tumor comes back, at that point, it's not a surprise to the patient if we bring up a cystectomy. Because otherwise, oftentimes they're like, but wait a minute, why are we talking about cystectomy again? I thought we were doing intravesical therapy and that would be it. So I tell the patient cystectomy is always on the cards. We're trying to avoid that. And I've found that makes that subsequent conversation as to a clinical trial, if you have a recurrence or cystectomy or what have you, a lot more palatable to the patients.
Yeah, I find like one of the more challenging thing is that the idea of cystectomy being a part of your management, either now or down the way, has never been brought up when they come to you. It's like a jaw-dropping experience that I was never told that my bladder might ever have to come out. Couple quick questions. So high risk, T1 high grade, whether that high risk is LVI or subhistology, etc. Are you taking those patients back for a resection to confirm that they don't have muscle-invasive bladder cancer and would benefit from potentially neoadjuvant chemotherapy? Or if you've got muscle, high-risk T1, are you typically okay going to cystectomy in that case?
Yeah, again, that's a very nuanced question, right? So at MD Anderson, we don't offer neoadjuvant chemotherapy to everybody with T2 disease. We only offer them to patients with T2 disease with histologic subtypes, T3B, hydronephrosis, LVI, etc. So if they're T1 disease and they want to have a radical cystectomy, I would not take them back for a re-TUR unless imaging or something else suggests that they might have been understage. On the other hand, if they want to save their bladder, I definitely take them back for a re-TUR because the risk of understaging a T1 disease, especially if it has all those nuances you talked about, is 40% in the best of hands, right? Even if muscle is present, it's at least 20%. So if a patient wants to embark on the journey to save his or her bladder, absolutely do a re-TUR for any T1 high-grade disease, even if I've done it myself, because that 20% incidence does exist. MRI, VIRADs, all of that are just adjuncts. They cannot replace a good quality repeat evaluation of the bladder and a re-TUR. Hope that answers your question.
Totally. So the T1 high grades that are getting cystectomy, they're kind of one path. The T1 high grades, they all get a re-TUR. Are there any TA high grade sub scenarios where you really like to get another TUR before you commit them to management strategy A, B, or C?
Yeah, we put on the guidelines that patients with high grade disease should be considered for re-TUR. And that's where that TA disease comes in. So if a patient's TA high grade and an expert such as yourself has done the resection, I don't necessarily take the patient back for re-TUR. But if the patient's referred to me by someone and I don't know that person, right? That person may be a phenomenal urologist, but I just don't know that person. I would prefer to go back and look again just to make sure that nothing was missed and that the resection needs was complete. And or if the tumor is multifocal, and even if I did the resection, but I'm not 100% sure I got it all, then yes, I would go back. But no, I don't routinely take every TA high-grade patient back to the OR for repeat resection, and most of us don't.
Okay, so now we've got our patient with or without a repeat TUR as clinically indicated. And are you using risk calculators? Do you sit down with EORTC, risk calculators, Querto tables, or is this 20 years later, I've got a pretty good sense of how you're going to do with respect to recurrence and progression?
I'm glad you brought that up, right? So if you look at the risk calculators, and we've published on this several times, they give you the risk of the patient's prognosis and outcomes without treatment. I don't think there's any patient that you and I are going to talk to that has high-grade, high-risk disease that we're going to say, okay, just go home. We're not going to treat you, right? If that patient asks me, hey, what if I have no treatment? Then sure, I'd plug them in the calculator. But those calculators are not useful for counseling patients that are actively pursuing treatment. So no, I don't use them as a matter of routine. I know our numbers. I know the current data. So I'll tell the patient, I'll give them the numbers. But those calculators overestimate the risk of progression. In fact, in the EORTC most recent update, if you plug in the numbers for a patient that's very high risk, it quotes you a 40% risk of progression. Then people get scared. But we know that's without any treatment, right? You give them BCG, and we published on this too. The risk of progression is in the low teens, if not single digits. So you got to keep that in mind. Perfect.
Yeah, I think in certain contexts, patients that are a little bit skeptical or maybe on one end of the spectrum where you're entertaining, de-escalating, it kind of makes some sense. But in the garden variety patient, I think it's more just knowing the data. All right, so high grade, let's just say by definition, higher risk bladder cancer, generally speaking, they're getting something, not nothing. Is that fair?
Absolutely. Absolutely. You know, again, in the U.S., unfortunately, a large percentage of patients still get nothing. If you look at this year and the Medicare reporting, et cetera, but obviously every patient should get some treatment.
What does that look like? And maybe we could just throw it out there. Is everybody getting BCG? Or are you putting patients on trial? How do you kind of think about this for your newly diagnosed, treatment-naive, high-grade, non-muscle-invasive bladder cancer?
Yeah, you know, it's been 40 plus years, and the reigning king of the treatment, the best immunotherapy we have for cancer, across all cancers, right, is still BCG. The response to BCG in bladder cancer is much better than immunotherapy for lung cancer or melanoma, what have you. So yes, BCG is still the reigning king, the number one recommendation, but there's a global shortage. And in the era of global shortages, Mike O'Donnell and his group, and then all of us subsequently, have adopted gemcitabine and docetaxel as a very reasonable alternative. And because of that, we have Max Cates leading the BRIDGE study, which is gemdosi versus BCG. So I will offer that study to my patients because we have it here and say, hey, would you like to enroll in the study? We think they're two equivalent arms. But if the patient says, what's current standard of care? It is BCG induction and then the SWOG protocol maintenance.
You know, I really appreciate you sharing that because it was something I kind of thought about and honestly struggle with a little bit. We have this study open here as well. When you're talking to patients, I absolutely think there's equipoise. We've got our kind of workhorse BCG. We've got a newcomer that's has retrospective data kind of suggesting it. And to make the study appealing without imbalancing, I think is a bit challenging. So I like that. You know, we've got two good options here. One's a workhorse, one's a newer kid on the block, so to speak. And could there potentially be some theoretical benefits other than the population level shortages of gemdosi as you see it?
It's, you know, a lot of this is hypothesis generating, right? Because one of the things is, would it make sense to use gemdosi first and then would the rescue with immunotherapy BCG be better, or is it better to do BCG first and rescue with gemdosi? We don't know. So that's why the trial is good to answer that question. The other thing is, are you going to combine a checkpoint inhibitor or some other immunological agent with gemdosi, or are you going to combine it with BCG? We have, of course, N803, which is in combination with BCG for the BCG unresponsive patients. It's IL-15. But with Pembro and BCG, those studies, is that going to show an efficacy with gemdosi? So there's a lot of data to be gained from the clinical study that I think will really help us inform the next generation of treatments for patients and even how to sequence these treatments.
Yeah, and honestly, that's the whole second half of this conversation. As we get more and more tools in our toolkit, I can envision a day where in the not too distant future, we're going to be like in kidney cancer world where it's, crossover designs and so forth. But we'll get there, of course. And you all have published on this with the shortages. I mean, this is something front and center for us. Literally, it's like, who can get what? And it's so frustrating. I know it's a reality for so many people. The induction for BCG, really try to get a full dose in there. Is that something that you think is important? And then maintenance, how much and what type of dilutions, if any, are acceptable?
Yes, I'm going to be controversial with my response to that question, right? Because yes, as a society, we put out guidelines to recommend at least, full dose induction, and then maintenance can be done at 1/3 dose so that you can give 3 patients a treatment on each vial. But if you really look at the way BCG is manufactured, whether it's the most common manufacturer in North America or if it's any other manufacturer, there's a 100-fold variation in the colony-forming units from each vial of BCG from batch to batch. So, one of my former fellows, Nate Brooks, he did the study and we published on it. If you look at a vial of BCG and compare it to the next vial of BCG and the next one, you could have a 100-fold variation. So if you take a vial that has 100 the CFUs and give a patient a full dose, you're giving that patient 100th of somebody else. And if you take someone that has 100 times the CFUs and give them 1/3, they're still getting 30 times this patient, right? So that's why all the studies suggest that reduced dose BCG is just as efficacious. And it makes perfect sense because we can't control for a 100-fold variation. And that's why I think this whole thing about full dose and 1/3 dose, which one is better, was answered very eloquently in the URTC study that showed that dose really doesn't matter that much. It's duration that's important. And because of that, I always stress that if you can give less dose but longer duration, do it, right? Try to get your patients to 3 years, especially the T1s and the CIS. TAs, if you don't have enough BCG and you have to stop at a year, that's okay. You can stop at a year. They will have higher recurrences, but as we know, a TA recurrence is not as dangerous as a T1 recurrence, and a CIS clearly is, it's even worse than a TA. So that's what we do. But no, at MD Anderson, we don't do full dose induction. We do 1/3 induction right off the bat, and we're able to give more patients BCG that way.
I appreciate you sharing that, and there's obviously some different kind of takes on this. Where I trained at Memorial, it was a little bit more induction forward, if you will, and then the duration of maintenance deprioritized a bit, however you want to phrase that. I do know for the bridge study that they do need to get a full dose induction, as I think just to standardize that and maybe get away from some of that variability. But that's what I love about these conversations is you get all the different perspectives. All right, so if you've gotten their induction course of BCG or maybe gemdosi if they're on trial and their 3-month cysto rolls up, maybe we can think about the starting being papillary disease with or without CIS. And then this first month cysto, we can run through it starting out with totally clean, normal cytology, atypical cytology, suspicious cytology, high-grade cytology, and then papillary tumor with or without CIS. So this is kind of a lot to, I guess, unpack here, but maybe how I'm kind of thinking about it. Let's just start out with the bladder looks okay, cytology is not normal. Worried, not worried? How do you kind of approach that scenario?
So Aditya, if the patient has CIS, like you mentioned, I don't even get a cytology at the first cystoscopy, right? Because it's really a piece of information that ends up being non-informative. Because the cytology is positive. Is it positive because of CIS? And if so, you're not going to do anything anyways, right? You don't really care if the CIS is there at 3 months because you haven't given BCG time to work. So if there is CIS, I wouldn't get a cytology, but let's assume there was no CIS and then the cystoscopy is completely normal and the cytology is negative. That patient's currently NED, so I'd continue on maintenance therapy.
Okay. So cytology positive, no initial CIS?
Yeah, so if there's no initial CIS and the cytology is positive, then I'm worried. I'm worried that I'm not seeing something in the bladder. I presume that I have already imaged the upper tracts just 3 months ago, but if I hadn't, I would worry there's something in the upper tracts. I'd also worry there's something in the prostatic urethra in men, because that's a site that might not have been sampled early on. So the bottom line is this is a patient I would take to the OR for blue light cystoscopy. So if I don't see anything in the clinic and the cytology is positive, that patient is getting counseled by me that, hey, we need to go back to the OR, use blue light. If I don't see anything with the blue light, then I'm going to look in the prostate, upper tracts, what have you. But if I see something with the blue light, I know what I'm looking at, and we'll do some biopsies there.
Okay. Do you do much office flexible blue light, or is this primarily in the operating room for you?
We used to, Aditya, but then Storts withdrew the support for the office tower, and we no longer have the office tower anymore. So I know some places were allowed to keep their office towers if they had them, and some places weren't. So we don't have an office tower anymore, and Storts is not going to provide any more equipment.
Okay, so prostatic urethra, upper tracts, if the bladder's looking okay, warrant a little bit of additional work. All right, erythematous patch, even on flex cysto in the office, concerning for CIS, positive cytology in a patient that previously didn't have CIS.
That's worrisome. If CIS is developing on BCG immunotherapy, that's actually worrisome, right? If the patient had CIS previously that was missed, and now you're seeing it, but you said it's visible, so it's actually getting worse, that's worrisome. So that patient, I mean, we would all consider being BCG unresponsive. You would document that on a biopsy, but giving the patient the benefit of the doubt and knowing that roughly 65% of CISs take 6 months to respond, I would still give that patient the opportunity to get another course of BCG, a maintenance course, or a reinduction, depending on if they did not get the full induction first, for the CIS to see if it goes away at that 6-month cystoscopy. So that's a patient I would file at the back of my mind as being high risk potentially for being BCG unresponsive, but hasn't met that criteria yet.
Yeah, I think this is all, every one of these times that there's a recurrence in my mind, it kind of goes back to, am I potentially putting this patient at risk of a missed opportunity of a window for cure if we wait 3 months? And a patch here or there with a bladder doesn't look awful. The short answer is I don't think I'm putting that patient at risk, and we can try something in the interim. Again, though, that conversation about, if this starts really progressing and heading in the wrong direction, we may be looking at more involved treatments. Okay, TA high grade, BCG, TA high grade.
That patient really is BCG unresponsive, but BCG refractory, right? So that patient now gets that conversation about, hey, standard of care, radical cystectomy, but you have TA high grade disease. I think it's safe to try and save the bladder. We have a clinical trial, and we do. But if you didn't have a clinical trial, then we have gemcitabine, which is a great non-approved off-label option. Or we have some approved drugs that we could also try, right? And those are Pembro and Adstiladrin, which is now actually available and ready to be used.
And then for the sake of completeness, T1 high grade, BCG, T1 high grade, are these, I don't want to kind of color your comments here.
No, feel free to color it, because I think you and I we're going to say the same thing, right? I mean, again, that patient also falls in the bucket of being BCG unresponsive, but that's a patient that is at a higher risk of having T2 disease that's not recognized. So really try to convince that patient, hey, remember we talked about cystectomy when you had that initial T1? We're talking now, and I'm really telling you that my primary recommendation still is a radical cystectomy. Do you want to go for it or not? And if a patient still says no, then I don't think it's unsafe. Even at this point, I don't think it's really unsafe, so long as that patient is willing to go on treatment X, whatever that is, and be closely monitored. So come back for that 3-month cystoscopy, do whatever needs to be done, not kind of like just disappear. I think it's okay to give the patient at least one more shot, even with T1 disease. But if they ask me point blank, what's the safest oncologic option? It is a radical cystectomy.
Okay, so a couple of terms that you and I are familiar with that you mentioned, BCG refractory. We didn't really touch on BCG intolerant. Maybe a couple of the terms that you find yourself using and how you explain them to patients when we're talking about this disease state now.
Yeah, so, I brought up the term BCG unresponsive, right? And that was a term that a group of experts, the International Bladder Cancer Group, and then the GU ASCO group led by Seth Lerner, along with the FDA and the AUA, sort of like, different iterations came together mainly to create the definition to help with clinical trials. So that's not, and never was meant to be a terminology to be used in the clinic. I know a lot of people use it in the clinic, and you and I have been talking about it in that term, but it was never meant to say that that patient is BCG unresponsive and hence you should do this treatment. It was merely to tell the FDA, and the FDA to then in turn tell pharma companies and investigators that, okay, you can enroll that patient in a single-arm study and we will consider the data to allow the drug to be approved. But the other terms are something that really make a lot more sense when we're thinking about and talking to the patient. So any patient who has a tumor despite BCG is essentially falls in the category of BCG having failed in that patient, right? And then is that BCG intolerant? Patient could not get adequate BCG at all, so that's BCG intolerant. Did the tumor ever go away and then come back? That's BCG relapsing because there was a disease-free interval. And did the tumor never go away? That's BCG refractory. There's enough evidence in small retrospective series, including some of ours, to suggest that the refractory patients tend to do a little bit worse than the relapsing patients, especially if the relapsing patients had a more than 18 to 24-month interval where they were disease-free. And that's what I will use to kind of let the patient know what risk bucket they fall into, even within this, BCG failure bucket. So yeah, it's a nuanced discussion. Some patients don't want to hear all this, right? They're like, just tell me, like, what are my chances? And some patients are like, well, what exact bucket do I fall in? So I think we have to tailor our discussion according to how much the patient wants to know too.
Absolutely. I can't help but chuckle. I mean, see patients in a lot of different contexts, a lot of different backgrounds, and I think, it's absolutely incumbent on us to be able to have that conversation in as much detail as the patient wants. And with more and more information out there, they're coming in well-educated, no question about it. So maybe let's just talk about how you think about the comprehensive armamentarium of tools in your toolkit today when you have a patient that essentially has BCG refractory disease.
Yeah, so if a patient has BCG refractory disease, right, I mean, that is pretty much the big unmet need several years ago where there was nothing really happening. We had one approved drug, valrubicin, which had a 4% 2-year disease-free survival, and then we had nothing else. And now we have a whole bunch of drugs out there, some that are approved, some that are likely to be approved by the time this podcast is released, and some that are on their way to being approved in clinical trials. So there's a lot of different moving parts here. I think the unfortunate thing for us still is that there is no predictive marker, and maybe we'll have some, but we just did a retreat here in Houston last year. The International Bladder Cancer Group spent a whole day and a half dissecting exactly this question. Which agent to use at what time after BCG? Do we have markers? Not. And the bottom line is no. There's no predictive marker at this point that helps us predict which salvage treatment is appropriate for which patient. So at this point, it's a discussion with the patient. It's, okay, we have these 3 things available right now for use in the clinic. One is pembrolizumab, which is approved. Etidine approved. Gemdosi non-approved, but sort of like the de facto standard in the US. And or we have clinical trials that we could, enroll you in. And then that question comes up from the patient, right? Well, what would you do? So that's where you and I have to kind of figure out what would we do if we were in the patient's shoes. And personally, if I had a patient in front of me that had BCG refractory disease and had a high likelihood of having micrometastatic disease, I think that's a patient in whom I would lean more towards pembro because it has some systemic activity. But short of that, my current recommendation outside of a clinical trial for patients is gemcitabine and docetaxel.
Yeah, I think, it's a little hard for me to, I guess if I'm worried, then it's going to be more, of course, cystectomy is a part of this conversation. And pembro, if I'm less worried, it's going to be more intravesical disease. I don't do a lot of reinduction BCG for BCG refractory disease. Maybe get your opinion on that before we put a nail in that coffin or resurrect it.
Yeah, I don't think we could have put a nail in that coffin, right? Because what's happened is exactly because of the misconception that BCG unresponsive terminology means it's a clinical definition. A lot of people think that if a patient is BCG unresponsive, it means you should never do any more BCG. And that's not true, right? Again, most patients will not do well with BCG, but we actually looked at this and one of our fellows presented the data at the EAU recently and got, an award for it. If you select our patients appropriately, and again, there's no real way to select it other than the nuances that you and I have been talking about, with repeat BCG in our series of patients that were BCG unresponsive, the CR at 3 months was 73%, duration of response 80 months, right? So clearly BCG does have a role to play in selected patients. It's not for everybody. So it's something just to have a discussion with the patient. I know the folks in New York use reinduction much more than we do or other people do as well. But there is a role for more BCG, but it's not something where we would tell everybody to get more BCG, because if they have not responded to BCG and we have other options, why not try something else and then come back to BCG if you need to in the future?
Perfect. So, comprehensively, again, in my mind, it's cystectomy, clinical trials, Adstiladrin, IV Pembro. Those are our kind of workhorses, FDA approved. We have gemdosi, definitely use a lot of it here as well. Again, for the folks that I'm kind of not worried about. We'll talk a bit about sequencing, but another maybe underutilized tool, chemoradiation. Any opinions on that, Ashish?
Yeah, a lot of strong opinions on that, right? We've had debates on multiple different stages. I'm a big proponent of bladder sparing. I'm a big proponent of allowing our patients to spare their bladders. And if a patient has appropriate T2 disease, appropriate T3 disease even, I think there's a role for chemoradiation for selected patients. I think when it comes to the non-invasive setting, the clinical trials that are currently being done are great because we're looking at IO plus or minus chemoradiation, etc., and they'll answer that question. But I think people forget that CIS does not respond to radiotherapy. And a lot of our patients that are BCG unresponsive have CIS, right? So now you're taking an entity that doesn't respond to radiation and you're trying to force radiation on it. So I don't think that's a good option for patients. It needs to be studied. I have nothing against clinical trials there, but it's always been a factor that even our radiation oncology colleagues say, hey, don't put this patient on radiation if they have CIS. So we've got to keep that in mind. The other thing is that heavily pre-treated bladders, which don't exist in the T2 population, but do exist in the non-muscle invasive population, patients already are having irritative voiding symptoms. We need to be cognizant of that before we send the patient to our radiation oncology colleagues, because our poor rad-onc colleagues will see the patient start radiation and the patient just is so miserable, they send them right back to you, right? And we're the urologist. We have to educate the patient better as to the nuances and the implications of radiation therapy. So short answer, I think there's a role, but it's going to be in very selected patients.
Yeah, I appreciate that. And I mean, the idea that it's got to be a bladder worth saving is always, I think, one to kind of keep front and center when thinking about bladder sparing approaches. All right, so you touched on it a little bit. If you're worried, maybe that could be a patient who really is pushing for bladder sparing. If you're worried about micrometastases, Pembro could be a good option. Intravesical therapy, well, let me just back up. Maybe if they've had a really gangbusters recurrence, multifocal, nodular, CIS, T1 high grade, that's a patient that probably really needs a cystectomy as long as they're fit and willing to receive that. But Adstiladrin, gemdosi, intravesical sequencing, any opinions at all there?
Yeah, I think if you look at the data, right, and you look at what matters to the patient is what is the chance that he or she will be free of disease at 12 months, 18 months, 24 months, etc. That 3 months, 6 months, probably most patients don't care about. And if you look at the numbers there, Adstiladrin has prospectively collected data that suggests about 24% at 12 months. Gemdosi has retrospectively collected data that suggests it's 55, 60% at 12 months. So with the caveat that one is retrospective and one is prospective, but recognizing that even Adstiladrin was not a randomized study, I think when it's up to us to offer that education to the patients and help them make an informed decision. Most patients tend to want to go with the treatment that has a higher number, and hence gemdosi kind of jumps up. I think accelleron has a really good role to play in patients that have access issues, right? Patients that are driving 3 hours, they can't come to see you. They're having to have their grandchild or someone take time off to drive them to see you. They might be better served by an agent that, yes, it's lower efficacy rate, but it's once every 3 months. It's not every week for 6 weeks, right? And so in those patients, you can say, well, let's try this drug. It's only once every 3 months. And if you have a recurrence, we can go to this more intensive therapy. But then at the same time, you and I have to be better stewards of healthcare dollars, and we have to factor in the cost of each treatment. So it's a very nuanced discussion. And again, all of what you and I are talking about right now is what I discuss with the patient, and we kind of come to a shared decision as to the next steps.
Couldn't agree more. I mean, I think there's so many things to consider when making these decisions. And I was actually just trying to think about, say, an ideal state study, and you've got your BCG refractory patients, and they get, let's just say today, and in 6 weeks, it's going to get infinitely more complex. They start out with either accelleron or gemdosi or pembro, and if they recur, they get randomized to X, Y, or Z, and you've got these 3 arms with all these different kind of crossover options in there. Probably not realistic in the short term, and of course, with biomarkers, as you mentioned, maybe we could do a better job, like we've seen in prostate cancer, for instance, of how to sequence these. But right now, I think you captured it really well. Here's the data, here's the quality of the data, here's some logistical concerns, here's some you-specific concerns, here's some your tumor-specific concerns. What do you think? It's turning into shared decision-making as opposed to your options are another course of BCG, valrubicin, which is not going to work, or cystectomy. Go ahead and take your pick. Well, there's not going to be a clear cut. Here's a neon sign that pops up that says, here's the next best option for you. That becomes abundantly clear. We've got options and we didn't used to. Maybe I'll ask you a couple of kind of questions down the way. Clinical trials, I mean, you mentioned the definitions put together by the International Bladder Cancer Group for single-arm studies. Single-arm studies, are those even going to be a part of how we manage this disease? Is that going to work anymore?
I've been a strong proponent of vocally saying that we need to get away from single-arm studies, right? The whole reason that the groups and the FDA adopted that BCG unresponsive definition was because nothing was happening. And now a lot has happened, and we've talked about the drugs that are approved, but of course there are other agents such as N803 plus BCG, which has its PDUFA coming up. There's CG Oncology's drug, cretostimogene, which has really good results. Johnson & Johnson's agent TAR-200, which has good results. The Engine trial. I mean, there's lots of good agents that potentially could be approved. And are we just going to stick? Well, for those that have already started the trials and are almost finishing, sure, let them finish out their single-arm studies. Let the FDA be true to their letter. But I think we need to now require a control arm, right? We need to have a control arm against something, because we can't continue to go on these single-arm studies giving these hugely variable numbers. Is it because patient selection has gotten better that we are seeing better results with the newer drugs? Are you and I recognizing that a particular type of tumor is better responding? Are we allowing reinduction, right? With pembro, if a patient recurred, they came off study. With accelleron, if they recurred, they came off study. But with all the other drugs, if they recurred but then progressed, they were allowed the option of repeat treatment. Is that what's driving the response rates? We don't know. So I think it's high time we start, saying let's do good quality trials, and a good quality trial requires a control arm.
Yeah, I appreciate you sharing that, and I tend to agree. I also think it's important. We have made tremendous strides. It's easy enough to play Monday morning quarterback and kind of sit back and judge, but it is really nice to see these, and now we do have, I would say, more robust controls than existed. So in my kind of show notes here, I had, what are you most excited about? You named, this is amazing. 4 studies just off the cuff that are going to be reading out in the next 4 to 6 months, and that could be practice changing. J&J, CG Oncology, Immunity Bio with the IL-15 superagonist. Earlier, you talked about a day and a half discussing biomarkers and predictive. So we've got new drugs coming through the pipeline, work to be done on biomarkers. What else kind of makes you optimistic and excited about the future?
When it comes to bladder cancer, you mean, right?
Yeah. We'll stay on topic. Otherwise, it could be another hour.
It's an exciting time to be in bladder cancer for us, right? For us that have seen not much happening and now so much happening. I think markers, right? I mean, predictive and prognostic and companion diagnostic markers are really where we need to focus our energies. And people are doing that. I mean, there's urinary ctDNA. It's like we've used FISH for many years, and FISH is coming back to see whether we can actually couple that with response to some of these newer agents. I think the ability to allow us to figure out which drug for what patient, I think should be the next goal for everybody doing research in this field. Because like you said, there's no clear winner, right? It's going to be, yes, the response rate is X, and you're going to offer the patient the different treatments. And each patient is going to look at us and say, well, what should I get? And then we're going to have to go back to stage, grade, nuances, which, again, don't get me wrong, they're great clinical parameters that allow us to make decisions to patients. But we're in a modern era. We have machine learning tools. We have the ability to do AI on pathology. We have the ability to do genome sequencing, which we do. But we haven't yet come upon a signature that predicts response to any of these agents. So we need to, right? The bottom line is that's what I'm excited about. Finding someone that comes and does the data, or us, you or I doing it, and figuring out what's the marker that lets us predict what drug for which patient.
Well, I love that. Ashish, I've learned a tremendous amount over the course of our time together. Thank you for sharing your insight and your expertise. As we come across an hour here, and I really do think I could talk to another hour about this, what are some parting thoughts for the listenership?
Parting thoughts to listenership, since we're talking about high-grade disease, is make sure you diagnose high-grade disease, assign it the appropriate risk category, which is high risk. Make sure the patient's not understaged. Make sure the patient understands the importance and the aggressiveness of the disease, because the biggest disservice we can do our patient is give them a complete false sense of security that lulls the patient into not wanting or not being able to be motivated enough to do the treatment right? And then after that, it's standard of care, which is currently BCG immunotherapy. Gemdosi is an option, but on a clinical trial. And then it's all these other agents that are available. It's up to us to be better stewards of not only the response rate discussion with the patient, but also remember healthcare dollars, right? They're precious. We need to make sure we don't waste resources, which is dollars, but also don't waste resources, which is our patients' lives. And we have to recognize that window of opportunity for cure. And if we think, you and I, that a patient in front of us is not going to have a good outcome as far as morbidity and mortality is concerned from the bladder cancer, pull the trigger and reinforce the bladder should come out at this point, right? So the whole journey that we talked about in a nutshell.
Well, thank you, Ashish. Congrats on the work that you've done in this field, really across the spectrum, and ultimately, of course, benefiting our patients who are true north. All right, we'll look forward to seeing you at the AUA here in San Antonio, and keep it up.
Thank you so much. It was a pleasure being with you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.